people wind up. So how is this analogous to taking this with meals? Well, dietary proteins. So I think a lot of you know that dietary proteins are basically strings of amino acids. When you digest proteins, you liberate all these amino acids into the circulation. So they're circulating there, and they're in competition for getting on that binding, that transporter protein that's going to carry amino acids into the brain. And you only have so many seats on the train, and if they are occupied by dietary amino acids, levodopa can't get on board. How do I know that this is important? Well, I can tell you that the first years of levodopa, there's a very stable response. Once you get the dose right, then people, they're very pleased, they're walking well, they can be early or late on a dose, but they get an effect that is very stable no matter when they take the dose, their 3 doses, over the course of 24 hours. After a period of years, the response gets tied to each dose in part. So these are the people that say that, well, I get up in the morning, I haven't taken any levodopa since last night, I have trouble walking, I shuffle to the bathroom, I take a dose, takes an hour to work, and then I walk normally, but it wears off in 4 hours. So I can tell you, I've seen a lot of people, not hundreds, but probably thousands, that have told me if I take it with a meal, it doesn't work. And it's interesting, the response is often all or none. Either it works or it doesn't work. So the person that took the levodopa with breakfast, when normally if they'd taken it on an empty stomach, they could walk well once it kicked in, they'll say, I still shuffle when I take it with food. Is that common? Yeah. Does that happen a lot? Yes, in those folks. So that's how you can tell that it's actually a pretty big deal that you need to take the carbidopa levodopa, and I've got on the bottom here, at least 1 hour before meals and at least 2 hours after the end of meals. And so if you take it 20 minutes before, there's some people that can sneak by with that, but it depends on how rapidly the carbidopa levodopa pill disintegrates in your stomach and gets into the bloodstream and so on. And so I've learned that to be sure, I tell people it needs to be at least 1 hour before meals. And then eat a meal, okay? All of our American diets have a lot of protein in them. Once you digest that protein and you liberate all those amino acids into the circulation, they're circulating for around a couple of hours. So again, I came up with the 2 hours not by making this up, and there's nothing that's really published on this, but it's people telling me. You know, I'd ask them, well, how long do you have to wait before you get a non-response from a dose of levodopa? These people who've had Parkinson's disease for years, and they have these wearing off responses. And sometimes I won't ask it that way. I'll just ask them, well, when did you take your last dose? It isn't working. And they'll say, oh, I just took it about 2 hours ago, but I ate, you know. And so you can kind of figure out how long these dietary amino acids are problematic. And so that's how I figured out they really circulate for a couple of hours after a meal. And then it's fair game again. And then they have the circulation cleared of amino acids, and they can take carbidopa levodopa without fear of having meals turning it off. Myth number 7, controlled release carbidopa levodopa is preferred. So the old brand name for that was Cinnamon CR. When that first came out about 20 years ago, I'm pretty sure that there were some neurologists who were paid a fair amount of money to say that, well, this is now the preferred form of carbidopa levodopa to take. Well, it is carbidopa levodopa. The problem with this formulation, I'm not opposed to this, but the problem is it's not fully absorbed. Controlled release products are formulated in such a way that the active ingredient is put into a sticky matrix, and in your stomach it isn't all released. And some of it goes through the small intestine and then into the colon. Once you're in the colon, you know, game's over because it's going into the toilet. And that's the problem with all the controlled release products to a variable extent. It depends on that sticky matrix. But with controlled release, it's hard to tell exactly what the dose should be. So I realized that if I'm going to keep it simple for patients and for me, I want to use a formulation where I can say, if you do this and this and this, we're doing the best we can. So I'm not opposed to Cinnamon CR. People that come in and they're fabulous on a dose of Cinnamon CR. I don't change anything. But if I'm starting from ground zero with people, I need to know that if I tell you take doses within this range, that you're going to have a good response. I put in here Dietary again. I happen to like Dietary, but I don't use it in new folks. It's $2.80 a capsule as opposed to 19 cents for carbidopa levodopa. That isn't why I don't like it, although it's one of the reasons I get pissed off sometimes about that. But the fact of the matter is that Dietary really has one purpose, and that's for these people with wearing off of the effect. And you can extend the duration of the response by 1 hour with Dietary. And that's the last time I'm going to say anything about that. So, if you saw me in the clinic and you're kind of walking like this and kind of slow, and your spouse says, boy, he's really slowed down in the last couple of years, and I recognize this is Parkinson's disease, this is the conversation we're going to have. And this is, I have a handout that basically is this handout, and I put it in that book that some of you have read. And this is the simple strategy for optimizing levodopa. Now, I've learned a lot of things from patients, and one of those is that I have people take up to 3 tablets at a time, but I've never seen anybody who does better on 4 tablets at a time or 5 tablets at a time. So that's how I know the dosing range, because it's somewhere between 1 and 3 tablets each dose. So what I do is have people take 1 carbidopa levodopa tablet for a week, and it takes a week for this cumulative effect to occur, and then they go from 1 to 1.5 to 2 to 2.5. And by my estimate I'm looking for the dose that works the best. I'm not looking for any other parameter other than I want you, the person I'm seeing in the clinic, as close to perfect as we can get you. And why wouldn't I want that? But anyway, some people say that, well, I think, maybe you're giving too much. And my response is, how do you answer that? But I do know what's too much is that people are taking 4 tablets at a time. I have not seen any incremental benefit from that compared to 3 tablets or less. So what I do, typically in my clinic, I'll tell people I'd like to see you back in about 6 weeks. Sometimes if they're from far away, they might choose to come a little bit after that. But then the idea is, let's you and I figure out the dose that works the best. And just from experience, my crude estimate is about, and if 2 doses work the same, why take the higher if you do just as well in the lower dose? So based upon those premises, I would estimate that about 10% of people say, boy, I got a really great response in 1 tablet 3 times a day. 10% would tell you that, well, 3 tablets really work the best. I'd like to stick with that. And most people would end up on 2 or 2.5 tablets each dose. And those are just the way things play out. And again, my goal is to get people as close to perfect as I can. It's rare that people have a perfectly normal response. It's probably 10% of people that have a normal, if you've been to a doctor that does Parkinson's disease exams, he or she has you do this and do that and walk, and they look at your arm swing and so on. So if this were the perfect drug, everybody would have a 0 score on that. And in my clinic, it's probably no more than 10% or even less than that people get 0 scores. But a lot of times the scores are pretty low, and as I mentioned before, I'm looking for 70 to 80% improvement with the levodopa. Now there's some people that come back and they're just the same, they've done everything right. How do you interpret that? Well, it ain't Parkinson's disease, unfortunately. So that's multiple system atrophy, progressive supranuclear palsy, or you missed the diagnosis altogether. So if you have Parkinson's disease, you should improve with this on the order of 70 to 80%. And of course, if you're over age 50, or rather over age 80, then it's unclear how good you're going to get, but you should have perceptible improvement even after age 80. And you can see here I emphasized on an empty stomach, because every once in a while I'll see somebody that says that, well, I did everything you said there and it didn't work. And then I'll ask them about, meals and taking it with meals, because sometimes it's just kind of hard to work in 3 doses, and I understand that. But you really need to be religious and do this properly. Myth number 8, the dopamine agonist drugs are nearly as effective as levodopa. A dopamine agonist is a drug that works just like dopamine. It's not levodopa, it works just like dopamine, and it's a synthetic form of dopamine. And the 2 drugs that have been around for quite a while go back to the mid-1990s when they came out. Pramipexole, which is Mirapex, or Pinrol, which is Requip. Those don't bind to all the dopamine receptors. There are 5 classes of dopamine receptors, D1, D2, D3, D45. They predominantly bind to the D3 receptors. And they just aren't as good as levodopa, no matter what the dose is that you administer. And the interesting thing, as I listed here, unique side effects of pramipexole and ropinirole. 1 person in 4 in our clinic. How would I know that? Because one of my senior colleagues tabulated pathological behaviors among people who were taking Requip or Mirapex. 1 person in 4 developed pathological behaviors, which included gambling, that was the most common, hypersexual, inappropriate things. This isn't just, you know, your libido went up a little bit. This is you became a pornography addict, or I heard quite a few stories. I got to know a lot of these people, and a guy who had been sort of just a run-of-the-mill Minnesotan, who were all normal in Minnesota. You know, if you listen to the radio, you realize that Minnesotans are really sort of the prototypic American. But these are guys that had been prototypic Americans for years, but all of a sudden they're chasing their wife around the house and demanding sex like 10 times a day and can't get an erection. So stuff that's really crazy. Anything that's inherently rewarding was being facilitated by these drugs. And then there's I don't know what the percentage is here, it might be 1 in 10, but they get sleepy taking those drugs. So the first paper written about that was just after these drugs came out in 1999, and Stephen Foote from Columbia reported 9 cases of people that got into car accidents because they were falling asleep after taking pramipexole or Requip. Hallucinations, you might think that, well, that's something that levodopa, being as good as it is, would really provoke. In my experience, hallucinations, delusions are really not all that problematic with levodopa. In fact, it's pretty exceptional that people run into trouble with hallucinations provoked by carbidopa levodopa. But it's pretty common that ropinirole, which is Requip, or Mirapex, which is pramipexole, provoke hallucinations. So people that I see are seeing pink elephants. One of the first things I do, maybe the first thing, is I look at the medicine list. I'm looking for all those ancillary drugs besides carbidopa levodopa, and I would guess that the vast majority of the time it's those drugs that can be eliminated, and you can eliminate hallucinations. Myth number 9, levodopa disrupts sleep. Well, I still hear that sometimes. You know, people that have insomnia, and they've been on carbidopa levodopa for years, and the 3rd and last dose of the day is at 5 p.m., and they can't get to sleep at night. Well, I remember reading this as a resident. There were people who were well-known Parkinson experts that say never give levodopa at bedtime because it disrupts sleep architecture. Well, what about 10 zillion people have taught me is that if you are in a levodopa unmedicated state, or your levodopa effect has worn off, you can't get to sleep. And if you think about it, those of you that have Parkinson's disease in the audience know that if you're in an unmedicated state or an off state, you can't get comfortable. People get sort of the heebie-jeebies. The term for that is akathisia, feeling restless, feeling like you can't move and get comfortable. And that's common in Parkinson's disease, and it is incompatible with getting to sleep. So people that have insomnia, let's say that they've had Parkinson's disease for 5 years, and they're doing great in the office. Their Parkinson exam looks pretty close to normal, and they're happy with everything, but can't get to sleep at night. And they're taking 3 doses a day, and the last one's at 5 p.m. Right? What do you think I tell them? Take another full dose about an hour before you go to sleep. Now, I mentioned full dose because people teach you things, and one of the things I learned was that intuitively people think that, well, it's sleep, I only need 1 tablet. You need the dose that works during the waking day. So that's the dose you take about an hour before you go to bed, so it has a chance to kick in. And then when it does, then hopefully you can sleep through the night. Well, people don't always do what you want them to do. So sometimes then they'll come back and say, well, this is great, but I woke up at 3 o'clock in the morning and I can't get back to sleep. Why is that? Well, I just can't get comfortable. So then what I tell them is, have another full dose on your nightstand with a glass of water to take. If you take that, it takes an hour to kick in, then you should be able to attain natural sleep once again. So this myth about levodopa disrupting sleep is actually, it's 180 degrees wrong. Myth number 10, we have drugs that may slow the progression of Parkinson's disease. So there's a whole list of drugs that have been tried with the thought being that the progression of Parkinson's disease may be slowed, and I've listed 11 drugs, that have undergone clinical trials that are randomized, controlled, and involved at least 100 patients, and 11 out of 11 are failures, including the more recent ones such as Ahlskog or Sagilate. That wasn't a failure, just the study was so complicated, you really couldn't figure out what in the heck was going on in that study. They were switching people from one drug to the other, and they claimed it was randomized and controlled, and people didn't know what drug they were on, but Ahlskog actually has a mild symptomatic effect, and people would do better on that. So people a lot of times would know what drug they're on as opposed to a sugar pill. So we have no drugs, and I think most neurologists in their honest moments would agree with this. We have no drugs that slow the progression of Parkinson's disease. And so this is the next few minutes before I wrap things up. Evidence that regular, vigorous exercise may slow Parkinson's disease progression. Well, I wanted to give you the whole lecture on this. A, I'd put you to sleep, and B, it would take probably 80 slides and a lot more than you wanted to know. So I've just picked out a few of the slides, and this is based upon the published literature from all the medical journals that are available, and those of you that ever scan medical journals, you know you can go to websites like the NIH PubMed website, and you can type in a search term like Parkinson's disease, and you can get every paper published on that topic in the last, probably goes back to the 1960s. And you can put in search terms like Parkinson's disease and exercise, etc. So this is how I just picked out some of the more illustrative kinds of papers that I thought are relevant to this discussion. So this is an interesting topic here. People that develop Parkinson's disease, people that didn't develop Parkinson's disease. It turns out that people that exercised in midlife have a statistically lower risk of later coming down with Parkinson's disease. So this was first published by several papers, and there was a meta-analysis on this published in 2010. Meta-analysis is when they combine studies that have similar methodology. So they concluded that 4 out of 4 studies documented that, but there have been 3 larger studies since then, one from Finland, one from Sweden, and one from Los Angeles, that found exactly the same thing. So people that exercise in midlife have a lower risk of later coming down with Parkinson's disease. Now you might say this is reverse causation. Maybe people destined to have Parkinson's disease are disinclined to exercise, and that's a fair criticism. So we need to look at some other stuff as well too. Now if I had Parkinson's disease, the one thing that I'd like to avoid would be I would like to maintain my cognition. So I value that obviously if I'm a physician, but I would value that probably under any circumstances. I want to maintain my ability to balance the checkbook and so on. Unfortunately, there are no clinical trials that have looked at this, and it would be extremely difficult to design such a clinical trial, because dementia isn't something that starts at time 0, or, well, that's not entirely true, but I'm not going to digress there. But it's something that typically occurs after years and years. So you'd have to follow this cohort of people for many years and make certain that they did everything, and with the control group they didn't exercise, and the other group they exercised and had good fidelity to that exercise routine, and you could never do a study like that. So that's the study I'd like to see done. It'll never be done. But there have been studies that have looked at people who exercised in midlife and what is their risk of later coming down with dementia. Well, this is another meta-analysis, 11 studies, and it turns out that people that exercised in midlife, these are just normal folks, these aren't people with Parkinson's disease, had a statistically significantly lower risk of later coming down with dementia. That was published a number of years ago, 2009. There have been 4 papers since then. They all found the same thing, although one of those it was not statistically significant. And this is an interesting study, the Baltimore Longitudinal Study of Aging. So this is funded by the National Institute on Aging in the Baltimore, Washington, D.C., Bethesda area. And they had a large cohort of people. It was 1,400, but they whittled it down to 600 that got at least 2 IQ kinds of tests, cognitive testing that was done twice in intervals of a number of years. And then they looked at the trajectory of scores on those tests. So I'll just explain to you, these are 4 different components. It's like an IQ test, 4 different components. Words learned. Here's the group that was the least fit. Over a period of time, age 50, age 60, age 90, there was a trajectory where they learned fewer words over a period of decades. And here's another similar kind of test, age 50, 60, 70, again, perform more poorly as decades of life passed along. And this is just this is errors on those kinds of tests. Here's the solid line is the unfit group, and the more they age, from age 50 to 60 and so on, the more errors they made, and the same thing was true on this visual retention test as well. So the solid line are the people that were the least fit. And in this cohort, everybody had a fitness test that was done at time 0. So they didn't repeat that, but they just assumed if you're fit at age 50, hopefully you'll be more fit than the next person, and probably maybe you're continuing to engage in activities that maintain your fitness. So that might be a little bit of a problem, but on the average, that's probably what is a valid assumption in this context. So this dotted line here, those are the people that are the most fit in their cohort. And fitness is something that, this is the way physiologists define it. They have people get on a treadmill or an exercise bicycle. There's a trainer there who cracks the whip and says faster, 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 and then you identify what their maximum capacity is for exercise, and you look at the volume of oxygen uptake. And so that's something that's very measurable, and it's done in a lot of scientific settings. And so you can measure fitness reliably, that way nobody debates that. The people that were the most fit, they had a much more favorable trajectory. Here it's almost a flat line. Here it's descending, but it's not nearly as bad as the unfit group, and the same is true for the errors in the upper 2 curves. So if you're fit, you maintain some of your cognition throughout decades of life. Anyway, that would be one conclusion you could draw. Here's an interesting topic, volume of brain. If any of you are familiar with MRI brain scans, you know that after age 80, people's brains are pretty shrunken on the average. There's some that have maintained pretty good integrity, but if I would show you 2 randomly selected brain scans, one from a 25-year-old and one from an 85-year-old, you'd 10 out of 10 times pick out the 85-year-old, with knowing nothing more than this person's 85 and that person's 25, just because of a shrunken brain. So that's the cycle of life. That's why I'm getting my knees replaced later this year. I mean, you know, stuff happens, and it turns out that your brain shrinks with passing decades of life. So you can measure the volume of brain. There's software, free surfer software. You can measure selected volumes of brain tissue. So this is some really interesting stuff, I think. This is from the University of Pittsburgh, Kirk Erickson. This is the hippocampus, left and right hippocampus. You've got 2 hippocampi. Those of you that know about hippocampi, in people that have Alzheimer's disease, on the average that tends to shrink, tends to get smaller. Aging tends to do that to at least some extent as well too. What does a hippocampus do? It is a memory center. So memory is good, hippocampus is good, so you want a large hippocampus. So on this axis here, this is left hippocampus, right hippocampus. This is the fitness. So this is what I mentioned. You get on an exercise bicycle, pedal like crazy, what's the volume of oxygen uptake? These are the most fit, these are the least fit. So we'll just look at the left hippocampus. This is the volume of the hippocampus, which was measured on an MRI brain scan. The more fit you were, the bigger your hippocampus. So that looks to me like that's pretty desirable, I would think. If you have concerns about memory not quite as good as it used to be, well, the more fit you are, the more you can curtail that. Now the problem, of course, with human aging is we're all going to die someday and stuff happens, and no matter what you do, you know, things are going to happen. But this is one strategy you can use to reduce the risks. So this is a one-time kind of assessment, but the same group, Kirk Erickson from University of Pittsburgh, actually took 2 groups of seniors, and one of the groups were randomized to stretching and toning, so they're doing stuff like this, you know, And the other group was randomized to vigorous exercise, and they did that for 1 year. 3 times a day exercise versus stretching and toning. Hippocampi volumes were measured again, so there's the left hippocampus and the right. And you can see that over time, the group that exercised, now they didn't measure fitness, they just had these people engage in exercise, and the average hippocampus tended to enlarge a little bit in size. Now there's a limit to what you can do with this, and your hippocampus doesn't start coming out of your ears if you exercise. And these are kind of very tiny, tiny changes, but nonetheless, they're reproducible and they're statistically significant. And this has been reproduced in some other studies I've indicated there as well. And then the cortex. So we saw the cortex in one of those slides earlier. The cortex is where human thought occurs. Planning, what you're going to do tomorrow, remembering your hotel room number, etc. So the cortex is important for human thought, human cognition, and I won't belabor this, but no matter how you cut it, if you look at the size of the cortex in fitness, or people that exercise for 6 months, or people that reported they exercised, or people that exercised by way of walking, the cortex is larger than the group that's the control group who didn't exercise or wasn't fit or was randomized to the sedentary group. So the cortex also tends to it tends to shrink over time, which is what I mentioned in 80-year-olds. The cortex typically is pretty shrunken, people over the age 80. But there's some degree you can curtail that with exercise and getting fit. And it gets even more interesting with animal studies. So you might say, well, you can infer certain things, but how do you know what really is going on in the brain? Well, in animals, you can put an animal, this is rats and mice now, these are the animals. Here's a rat or a mouse cage, and you can choose to give a rat or a mouse a running wheel. Hamsters do this. So those of you that have kids with hamsters, you know that a hamster will get in a running wheel and run like crazy. Well, I spent 4 years in a PhD program where we would put rats in cages like this and let them run in a running wheel. Same thing happens. They would run and run and run. And you can count the revolutions with a counter, and then what you can do is compare that to the group of animals that got only a cage and no running wheel. And then what you do is, after some interval of time, typically would be about 6 months, you cut off their heads, extract their brains, and measure things. That's kind of crude, but that's science. And this is one of the most interesting things. Exercise liberates neurotrophic factors in the brain. What are neurotrophic factors? That's like farmers who put fertilizer in their fields to grow better soybeans and corn. This is like putting fertilizer in your brain. That's what neurotrophic factors are. And the two most commonly studied ones are BDNF, brain-derived neurotrophic factor. And in animals, 27 out of 27 studies documented that the brain BDNF level was raised with exercise compared to the sedentary control group who didn't get a running wheel. GDNF, glial-derived neurotrophic factor. Those of you that, probably nobody in this audience knows that, but about 10 years ago there were 5 different studies that looked at infusions of GDNF into the brains of people with Parkinson's disease. These are people who volunteered to have a cannula put in their brain. So a cannula is like a long hypodermic needle that's stuck into an area of the brain, and where this was infused was a striatum. And GDNF was infused, thinking that this will be good for that area of the brain. Well, it turns out that some of those 5 studies were positive and some were negative, and ultimately that whole line of research petered out. But you can see that there was confidence among neuroscientists that probably high levels of GDNF are good. And my thought is, given the choice between the cannula in my brain and exercise, I'm probably going to choose exercise. And then there are some other factors as well, too. And then finally, there are a number of things you can measure in the brain that relate to neuroplasticity. Neuroplasticity is what allows us to remember our hotel room number, remember where our car is parked, remember a whole bunch of stuff. Neuroplasticity is a constant remodeling that's going on when we're exposed to things. Remembering what you saw on TV last night or the book you just read, it's all neuroplasticity. And so these are the connections that are constantly being rewired. These synapses are the interfaces between, I showed you that long wire-like process, you know. Well, on the other side of that is a receptor. The neurotransmitter is released, and that activates the next link in the circuit. And things that become sort of hardwired, that basically is what neuroplasticity is all about. And the parameters of neuroplasticity in exercise animals go up. So genes that are responsible for neuroplasticity kinds of factors go up, the protein products of those genes, the proteins themselves go up, and you can measure those, again, in the brains of rats and mice that have been exercised. Neurogenesis. We make almost no new neurons in the brain. There's just very few areas where you make new neurons. Turns out that one of the few areas is the hippocampus, so that's called neurogenesis. And you can measure that, and every study in animals that's looked at hippocampal neurogenesis shows that the exercise group had the number of hippocampal cells increased for the time of the hippocampus. Long-term potentiation, that's the neurophysiologic substrate of memory, and that is facilitated as well too. And so now we're going to go back to humans again, and I think there's one other thing that's important to mention because it typically gets overlooked. But levodopa became available in 1969. Carbidopa became available along with levodopa in the mid-1970s. There were 7 different studies from 7 different medical centers that looked at longevity rates in the era just before carbidopa, levodopa, and levodopa became available and just after. And 7 out of 7 documented rather substantial increases in longevity. So that's interesting from the standpoint of what is that telling us about levodopa and Parkinson's disease? Well, a simple-minded thought would be, well, levodopa or dopamine must have something to do with the cause of Parkinson's disease, the perpetuation of Parkinson's disease. But in fact, I think that in the era before levodopa was available, remember I said that stage 5 in that old staging scheme was people that were basically chair and bed bound. Well, it's not too common to see those people anymore. If they get old enough, they've had Parkinson's disease for 25 years or age 85 years, that's a different story. But people that I see that have Parkinson's disease for 20 years, they're not stage 5. Typically, they're half the time they're not even stage 4, which means you need